Picture this. It's a Tuesday afternoon in your outpatient cardiology clinic.
Oh, the classic Tuesday afternoon rush.
Right. And you're staring at the chart of a patient you know really well. They have second-degree AV block, type 2, so Mobitz II, and they just recently had a permanent pacemaker implanted.
Okay, so a pretty standard scenario so far.
Exactly. They are sitting in the exam room right now, totally stable, feeling completely fine. But your scheduling coordinator is standing in the doorway asking you this deceptively simple question.
Let me guess. When do we bring them back?
You nailed it. They're asking, do we book their routine device interrogation for 3 months post-implant, or do we just push it all the way out to the 12-month mark?
Yeah, and it sounds like this purely administrative scheduling thing, but it is actually one of the most profound everyday clinical decisions you make.
Okay, let's unpack this. Because as healthcare professionals, you are constantly walking this tightrope, right?
Oh, absolutely.
You've got waiting rooms that are just already bursting at the seams, and obviously you don't want to miss some silent complication. But dragging a perfectly stable patient into the clinic for literally no reason.
It creates a massive bottleneck.
Right, it hurts everyone. Treat the pacemaker schedule kind of like car maintenance.
Okay, I like that.
Is the 3-month check that essential first oil change you have to do, or is it an unnecessary trip to the mechanic when the engine is running perfectly fine?
To answer that, we really have to look at what the clinical evidence actually dictates. And the reality here, which often genuinely surprises clinicians, is the sheer lack of high-confidence evidence.
Really? There's no solid data for the early check.
Well, none that proves a routine interrogation at 3 months catches more meaningful, actionable complications than just waiting until 12 months in a stable outpatient.
I mean, I have to challenge that premise right out of the gate. Mobitz II is uniquely treacherous.
It definitely has that reputation.
Right, because unlike a Wenckebach block, which, happens at the AV node and gives you that progressive warning.
APR prolongation. Yeah.
Exactly. But Mobitz II is an infranodal block, usually down below the bundle of His. If that conduction fails entirely, the escape rhythm from the ventricles is slow, wide, and just highly unreliable.
That is entirely true. The pathology itself is precarious.
So if we are dealing with a pathology that unpredictable, aren't we essentially flying blind by skipping an early check? Like, what is the actual harm in overchecking just to be absolutely safe?
So this raises a really important question about how we define safety in modern device management. Because historically, pacemakers were prone to premature battery depletion, lead fractures.
Threshold fluctuations, all of that.
Right. Frequent checks were dogma because the hardware actually demanded it. But today, the devices are incredibly robust.
So the technology outpaced the old scheduling habits.
Exactly. Sticking to usual care, which in a lot of clinics is an annual check that's not flying blind. It's an active, evidence-informed strategy.
Because the stable patient doesn't need that intense hardware oversight anymore.
Right. When you mandate a 3-month check for a truly stable patient, you are significantly increasing clinic burden. And that actively reduces access for patients who actually need urgent care.
Wow. Okay. And you're doing this without any proven mortality or morbidity benefit.
Exactly. Zero proven benefit for the stable population.
So going back to the car analogy, think of the pacemaker in a Mobitz II patient not just as an engine part, but as a backup generator for a building with a faulty main power grid.
I love that visual.
Right. If the lights are on, the building is functioning, and there are absolutely no alarms sounding, sending a technician to inspect the generator every few weeks is just a massive misallocation of resources.
That analogy perfectly captures the baseline rule here. If the patient is clinically stable, the 12-month mark, or honestly, whatever your local standard for usual care dictates.
Yeah, the standard clinic protocol.
Right, that schedule is entirely appropriate. You are not failing your patient by deferring to it. The data simply does not support the idea that early mandatory checks change the clinical trajectory for this specific stable group.
Okay, so if we establish that the baseline strategy is to wait 12 months for the stable folks, then the entire success of this approach...
It rests on knowing who isn't stable.
Exactly. It rests entirely on our ability to correctly identify who is no longer stable. We have to be fiercely vigilant about the specific clinical triggers that revoke a patient's stable status.
Absolutely. The exceptions are where you really earn your paycheck.
So let's start with the most obvious signal. The patient's own physical experience.
Yeah, symptoms are the ultimate trump card.
What kind of symptoms are we talking about specifically?
We're talking about new or worsening syncope, severe palpitations or unexplained dizziness, If your Mobitz II patient suddenly reports any of
You
these
bring them in immediately.
without hesitation, you have to suspect device malfunction, a drastic change in their underlying rhythm, or, an acute pacing threshold issue.
But we aren't just looking for a dramatic, syncopal episode here, right? Like, as clinicians, we have to be hunting for the subtle, insidious symptoms too.
Oh, definitely. The dramatic ones are easy to catch.
Right. I am thinking about things like pacemaker syndrome or just that subtle fatigue that comes from a loss of AV synchrony.
That is a really critical distinction because a patient might not pass out, but they might complain of a strange fullness in their neck.
The neck fullness.
Yeah, or maybe sudden exertional dyspnea that just wasn't there last month.
What causes that specific neck fullness feeling?
Well, in a Mobitz II patient, if the pacemaker is suddenly doing a massive amount of right ventricular pacing without proper AV synchrony, you can get retrograde VA conduction.
Ah, right. So the impulse travels backward.
Exactly. The ventricles contract, and the electrical impulse travels backward onto the atria. That causes the atria to contract against closed AV valves.
Which would cause Canon A waves.
You got it. Canon A waves in the jugular veins and a pretty significant drop in overall cardiac output.
Which perfectly explains that feeling of neck fullness and sudden fatigue. So if the patient is symptomatic, we expedite the check. That's a clear trigger.
Right.
But that assumes the patient actually feels the physiological shift. What if the patient is sitting there, feels totally fine, but the device's internal diagnostics detect an impending failure?
And that brings us to our second major trigger, which is device-generated alerts.
Even if they're completely asymptomatic.
Especially then, whether these alarms are detected remotely via home monitoring systems, or maybe just incidentally during a brief vital sign check in the clinic, they require prompt evaluation.
And we are talking about specific technical parameters crossing a threshold, right?
Exactly. Things like changes in lead impedance.
Which might signal, what, a microfracture in the lead insulation?
Right, or a sudden spike in pacing thresholds, meaning the device suddenly has to use significantly more battery power just to capture the myocardium.
Or what about arrhythmias, like a sudden onset of a high atrial fibrillation burden that the patient is entirely unaware of?
That's a huge one. You simply cannot ignore a technical alert just because the patient is sitting on the exam table smiling and claiming they feel perfectly fine.
This subjective feeling doesn't overrule the objective data.
Exactly. The device is literally telling you the physical environment of the heart has fundamentally changed.
Okay, so we have the patient's physical symptoms, and we have the device's internal diagnostics. But what about external forces acting upon the patient? Because the clinical landscape changes all the time outside of the heart itself.
Oh, major clinical events completely alter the risk calculus.
Like what kind of events?
Well, if your patient has a recent stroke, if they are entering a perioperative status for a major surgery where electrocautery might be used.
Oh, because of the electromagnetic interference.
Exactly. Or, crucially, if they undergo radiation therapy. In any of those cases, their scheduled 12-month interrogation timeline just goes completely out the window.
Radiation therapy is a brilliant example, actually, because we often hyper-focus on the patient's biological changes, and we forget that the pacemaker is a literal piece of technology sitting in a dynamic physical environment.
It's a microcomputer implanted in the chest.
Right. So why does a course of radiation force an immediate, unscheduled interrogation?
What's fascinating here is the physical vulnerability of the complementary metal oxide semiconductor, or CMOS, circuitry inside the pacemaker generator.
Wait, the physical microchips?
Yeah, the microchips themselves. Ionizing radiation doesn't just damage human DNA, it can actually cause the accumulation of electrical charge within the insulating layers of those microchips.
Oh, wow. So it's a hardware-level interference.
Yes. This scatter radiation can trigger transient or even permanent software resets, forcing the device into a generic backup pacing mode.
It can literally wipe the programmed memory.
It can. It absolutely can. And furthermore, radiation aimed at the thorax can cause localized tissue fibrosis right at the lead tip interface in the myocardium.
So the tissue itself changes where the lead connects.
Right. And that fibrosis acts as an electrical resistor. That causes the pacing thresholds to skyrocket, which obviously leads to premature battery depletion.
That makes a ton of sense. So a patient undergoing radiation is just a high-risk entity across the board.
Very high risk. Their device must be interrogated before, during, and after the therapy course.
Okay, so radiation is a dramatic external physical force. But as outpatient clinicians, We alter our patients' internal chemical environments constantly. We adjust medications every single day.
And medications are a massive, frequently overlooked trigger for expediting device checks.
Which classes of meds are the main culprits here?
Specifically, the initiation or upward titration of AV nodal blocking agents.
So your beta blockers, your non-dihydropyridine calcium channel blockers like diltiazem.
More antiarrhythmics like amiodarone.
Going back to our analogy for a second, prescribing a beta blocker to a Mobitz II patient is kind of like intentionally shutting off the main power grid.
That's exactly what it is.
You are forcing that backup generator to take on the entire electrical load of the building. We know Mobitz II is a precarious infrahesion block. If we introduce a drug that further suppresses conduction through the AV node, we aren't just tweaking a variable.
Yeah, you're not.
We are aggressively testing the fail-safes.
You're fundamentally altering the conduction landscape. You might convert an intermittent occasional block into a complete permanent heart block.
Which means their pacing burden goes from, what, maybe 10% to nearly 100% overnight?
Yes. And that skyrocketing pacing burden has severe consequences if the device isn't optimized for it.
Because it wasn't programmed to pace 100% of the time.
Right. The pacemaker might be functioning perfectly according to its current programming, but you need to verify that those parameters are still optimal for a patient who is now entirely pacemaker dependent.
You'd have to look at battery drain, for one.
You need to assess the drastic impact on battery longevity, absolutely. And you need to watch for EKG changes, like significant widening of the QRS complex in the unpaced beats.
Which would indicate the disease is progressing further down the His-Purkinje system.
Exactly. You simply cannot prescribe an AV nodal blocker to this patient and casually tell them, great, see you in a year.
It demands an immediate check. Okay, so we've covered symptoms, technical alerts, major clinical events like radiation, and medication changes.
But there is one more variable we have to account for.
Oh, right. And it's one that rarely shows up on a remote monitoring report. The human factor.
Yes. Patient or caregiver anxiety regarding the device.
How heavily should we weigh that compared to hard data?
You have to trust that human element. It deserves serious, immediate clinical attention.
Because they notice things the device algorithms don't.
Exactly. Patients and their spouses often pick up on subtle physiological declines long before they trigger a formal device alert or result in a catastrophic event.
I've seen this play out in the clinic so many times. The remote interrogation looks perfectly fine, the battery's robust, but the spouse pulls you aside and says, he's just not himself. He used to walk to the mailbox with ease, and now he has to stop halfway.
And that observation is a real clinical data point.
Even if the numbers look good.
Even then, that could be the earliest subclinical sign of right ventricular pacing-induced cardiomyopathy.
Because the right ventricle is not designed to be the primary pacemaker for the heart.
Exactly. It causes a desynchronous contraction that can slowly degrade the left ventricular ejection fraction over time.
So by taking the spouse's concerns seriously and expediting the clinic visit, you actually get ahead of it.
Yes, you can perform an echocardiogram, and you can adjust the pacemaker's AV delays or lower rate limits to minimize that unnecessary RV pacing. Expediting the check based on their subjective concern is simply good medicine.
Here's where it gets really interesting.
Okay, lay it on me.
We have established the baseline rule. Follow the usual care schedule for stable patients. And we've outlined the specific clinical triggers, the symptoms, alerts, meds, and human factors that demand you break that routine.
Right.
But bridging the gap between knowing these rules and actually applying them in a chaotic, high-volume clinic is incredibly difficult.
It is the hardest part of the job.
Because as clinicians, we are highly trained to rely on evidence-based medicine. We want the data, the randomized controlled trials, to give us a definitive algorithm to follow.
We all want the flowchart.
Right. But here, the data is essentially telling us we don't have enough statistical power to mandate a timeline.
Which creates a very uncomfortable cognitive dissonance for the practitioner.
Yeah.
You are asked to be rigorous without having a rigid framework to lean on.
And the danger is that a well-meaning clinician might misinterpret this absence of evidence as proof that timing simply doesn't matter.
Oh, that's a huge trap.
Which leads directly to dangerous, arbitrary scheduling. They might just pull a date out of thin air to make themselves feel better, falling into several clinical traps along the way. So how do we navigate that gray area?
By being acutely aware of the pitfalls. The first and most dangerous trap is adhering to the calendar at the expense of clinical presentation.
Like stubbornly sticking to the schedule no matter what.
Exactly. Assuming that waiting until 12 months is strictly safe, even when symptoms or alerts are actively present, simply because the patient's chart says scheduled for 12-month follow-up.
The schedule is just a logistical tool, not a physiological reality.
The calendar should never, under any circumstances, overrule acute clinical changes. If the parameters change, the schedule must change.
Okay, that's trap number one. What's the second?
The second major pitfall is extrapolation, and this happens constantly in cardiology.
Borrowing rules from other devices.
Yes, a practitioner will read a highly robust, well-powered study about interrogation timing for complex devices, like cardiac resynchronization therapy, CRT devices, or ICDs.
The implantable defibrillators.
Right, and they will improperly apply that intensive timeline to our Mobitz II patient with a standard permanent pacemaker.
I mean, I can see why CRT guidelines bleed over into standard pacemaker care. They are managed by the same electrophysiology teams. They're implanted in similar ways. They both sit in the chest.
It's an easy mistake to make on the surface.
So why is it a massive error to borrow a timeline from a CRT patient?
Because the underlying pathophysiology and the device algorithms are completely different.
In what way?
A CRT patient receiving biventricular pacing typically has advanced heart failure with reduced ejection fraction and a left bundle branch block.
So their heart is already failing fundamentally.
Yes, the entire goal of that device is to continuously resynchronize the left and right ventricles to improve cardiac output. The clinician needs to frequently monitor and optimize the AV and VV delays.
It's a highly active, dynamic therapy.
Exactly. And an ICD patient is at high risk for sudden cardiac death from ventricular tachycardia or fibrillation. Their need for frequent monitoring is driven by highly volatile pathology.
But a stable Mobitz II patient with a standard pacemaker.
That device is just acting as a safety net. It's a completely different clinical entity. Extrapolating data from one to the other is a profound workflow error that leads to massive overutilization of clinic resources.
You cannot treat a straightforward backup generator like a highly complex active resynchronization machine.
Perfectly said.
It makes me wonder if we also falsely project the anxiety of high-risk procedures onto our perfectly healthy patients, like the radiation therapy we discussed earlier.
And that is the third pitfall, the availability heuristic.
Getting anchored on recent scary events.
Exactly. You manage one complex patient who required a 3-month check because they were undergoing thoracic radiation, and the anxiety of that high-risk scenario just sticks in your mind.
So then you overcompensate.
Right. Consequently, you start ordering 3-month checks for your next 10 entirely stable, low-risk outpatients. You project the high-risk vigilance onto the low-risk population.
Which brings us to the final trap, I imagine. Relying on isolated anecdotes instead of aggregate data.
The infamous case report trap.
Right. You read a single terrifying case report in a journal about a 3-month interrogation that caught a completely asymptomatic, rare lead microdislodgement.
And suddenly you want to rewrite your entire clinic protocol to mandate early checks for everyone.
Just to avoid that 1 in a million scenario.
If we connect this to the bigger picture, what you are highlighting is the critical need for individualized medicine.
We have to treat the patient in front of us.
Exactly. We cannot lean on arbitrary fixed intervals or the fear generated by isolated case reports to save us from having to think critically.
The guidelines won't do the thinking for us.
Right. The absence of a rigidly mandated timeline does not mean you abandon oversight. It means your active clinical judgment, your hypervigilance for comorbidities, and your deep understanding of that specific patient's context must always override reliance on a calendar.
So if you are standing in the clinic doorway right now, and the scheduling coordinator needs a definitive answer for that Mobitz II patient sitting in exam room 3.
Here is the golden rule.
Let's hear it.
In stable patients with Mobitz type 2 AV block and permanent pacemakers, simply follow your local routine outpatient interrogation schedules.
Usually 12 months.
Usually 12 months. There is no evidence supporting a fixed mandatory early check for a stable patient. Treat the patient, not the calendar.
But stay vigilant.
However, you must maintain a razor-sharp awareness of the triggers. Promptly expedite that interrogation if symptoms like unexplained fatigue arise, if device alerts trigger, if you initiate a new AV nodal blocker.
Or if major clinical events like radiation therapy occur.
Yes. If they are stable, respect the routine. If the clinical landscape shifts, break the routine immediately.
So, what does this all mean for the future of our practice? We've spent this entire time debating calendar schedules, weighing the merits of 3 months versus 12 months, trying to fit the dynamic, unpredictable nature of a human heart into a static administrative calendar.
It is a bit archaic when you put it like that.
It is. But I want to leave you with a thought as you head back into the clinic. What if the future of cardiology completely eliminates the calendar altogether?
Well, that's an interesting concept.
Imagine a near future where continuous AI-driven remote monitoring is so advanced that the concept of a scheduled interrogation just becomes completely obsolete.
Where it's all handled in the background.
Exactly. The device is constantly analyzing pacing burdens, monitoring lead impedances, and calculating subtle shifts in right ventricular desynchrony in real time. But instead of generating a massive report for you to review every few months,
Which nobody has time to read anyway.
right, the AI only flags your clinic when a specific personalized physiological threshold is crossed.
So no more routine 3-month checks.
No more routine 12-month checks either. You only see the patient exactly when their physiology demands an intervention.
That would change everything.
How would that proactive, scheduleless paradigm permanently alter the landscape of your daily practice? What would you and your clinic staff do with all that freed up time and bandwidth?
It's a massive shift.
It is a paradigm shift that is coming faster than we think, moving us away from reactive, calendar-based medicine and toward truly proactive, physiology-based care. Something to ponder the next time you are staring at that scheduling screen. Until next time, keep your clinical judgment sharp.